The presentation I have here now is going to be a bit into, how do I say, complicated stuff about setting the Nava level, and that is in the sense that Nava is actually a muscle. Why we call it a muscle, I will try to explain to you. I have made some inventions and I have royalty for those, so shame on me, but that's what happens. So, anybody saw this TV show, The Bionic Woman? Probably most of you are too young. Anyway, she was, you see here, she lifts that little Mini Cooper there, whatever. She is like having this shoulder and arm thing that made her some superpower lady, whatever. And I found this other picture here on the internet yesterday, which is kind of showing some new device. I don't know what it's for, but it certainly is something with robotics. And why I put this in here is that all this sounds so easy. You make an electric prosthesis that helps you. But how does it work if you don't have a feedback? I mean, when are you going to hit yourself in the face, or when are you going to throw the coffee in your face, or when are you actually going to drink out of the mug? When you don't know where you are. Because how do you connect to the brain? The important thing is not to control the machine. That's easy. The important thing is to understand what the machine is doing and make it not overact. And that's like what I think that when we come to like a little bit more of talking about Nava as a mode of ventilation, this is actually like Jennifer came up with this slide for the Tobin textbook. I had something that was awfully complicated and nobody understood it. But this one I think is quite easy. Where you have that the patient is having his phrenic nerves generating the electrical activity. At the same time you have the diaphragm catheter who picks up the same signal. The diaphragm and the ventilator is from each side here. The neuromechanical coupling is here. You have the Nava level here. Patient gets weaker, you turn the level up. Patient gets stronger, you turn the level down. But the thing is also that if the patient gets stronger and gets more activity and the volume and ventilation goes up, well then in that case the patient turns down the activity himself. And that is the kind of interesting thing with Nava, that you can actually withdraw the assist if it becomes too much for you. And I mean, if we talk about the bad parts of mechanical ventilation, it's usually not associated with too little assist, it's usually associated with too much assist. So in the end we come out with the patient and ventilator pressure and get the lung distending transpulmonary pressure, which gives us the volume. So in order to control this, we have, like as Jennifer went through, a lot of the different feedback receptors here. And it's an extremely complicated area. But some of those we have tried to sort out in animal experiments, and we have looked in for diaphragm receptors, lung and lower airways, the CO2 receptors and so on. And that's what I'm going to try to bring you through here now, and you have to bear with me because it can get a little bit complicated. So we start first with the model we're going to work with here. So from now on we're going to talk about, Lucas likes to call it the Nava titration. And what we talk about is that we are simply going in on the ventilator and we start to turn this knob, which means we turn up the Nava level. So you see the assist goes up, and that's what we wanted, but also you see the drive goes down. That means that you don't get all what you want. The patient is holding back. So what we do is actually something that I try to illustrate here, and it has to do something with, you know the story about the tortoise and Achilles? How he runs after this tortoise. I mean, he is so many times faster, but all the time he just catches up half the way. So half of half is half, and half of half is half again, and so on. So you can only cut the distance in half all the time. And this is like another slide from the internet I found that kind of illustrates that story. But the thing is, he never catches up with the tortoise. So what I try to do here is to show them in a simple way, because I'm not a mathematician in any way. I work with some very nice ones, but I don't understand much myself. But to illustrate this one for dummies, this is like my way of thinking. And You take that this is the diaphragm activity that you see here, and we will consider that you had a linear increase in diaphragm activity with a linear increase of the Nava level. So you go 0, 1, 2, 3, 4, 5 in Nava level. And you go down activity linearly. Well, this is the pressure waveform you will see. So if you go from 40 microvolts or whatever we are at here, down to 20, you have reduced the drive by half. And in this case, we saw this was associated with an increase because we had a doubling of the Nava level. So we doubled the Nava level, but we only reduced the drive by half. We go from 2 to 3, or a little bit above. You see we come to 1/4. That means from half to a quarter, we halved the Nava level again between 20 and 10. But now we had like relatively less increase in we didn't double the EDI level, sorry, the Nava level. So therefore, we have like a withdrawal of assist of our drive that is so powerful that it actually cuts down the pressure in almost half, even if we are continually turning the knob with the same rate. So this means that from looking from this just from a pure mechanical mathematical formula is that the lower the level is, the faster you can halve your drive. So between 40 to 20, that's 20 microvolts, but 20 to 10 is 10 microvolts, 5 to 2.5. You only go down 2.5 microvolts and you are taking away half of the assist. Doesn't matter what the assist is. So when you are suppressed in drive, you have an enormous power over the assist. Once you come out at the end here, you can't reduce the Nava level, the drive anymore. And now the Nava level starts to go up again. And if we look in the patients, we've done studies, Lucas and I, and we have several studies, and we'll come back to those. So if you have instead that you put an exponential function of the reduction in drive, well, that's when you start to get this kind of plateau that we tend to see in the patients. The patient comes to a pressure which gives him a volume. At that volume, he is happy with his ventilation. And if you increase the Nava level more, I will just reduce my drive in order to keep what I have, that I'm happy with. So what we in fact do, we regulate the drive rather than to regulate the actual pressure. So you down-regulate the drive in the patient. The patient himself is more in control of his volume and pressure than you are. So when we do studies, when we try to hit target levels, we have to be within a very limited range because some pressures you can't just obtain with Nava. For example, Paolo showed that very nicely in his study, that you can't just get to certain pressure levels with Nava unless you totally over a system. So this is from the first study of acute lung injury here. This is with Jean-Christophe Vallot from Paris. And what we found in this very early study was that we found two factual things with the diaphragm response in the acute lung injury rabbit. And one thing is that when you get an acute lung injury and you remove the PEEP, is you get something we call tonic activity. So the diaphragm activity is very high, and they almost stop breathing. It's just an irregular, strange breathing pattern and very high tonic activity. If we apply PEEP to this, well, you shift the esophageal pressure towards more positive values, so you actually inflate the lung. And as the PEEP goes up, the more stable the breathing pattern and the lower the tonic activity. This is something we were able to show in babies, but it's not a rule. Not as in the rabbit model when you pour hydrochloric acid into the lung, you have the same type of injury. In a baby, it could be that you already have consolidation, and in that case, it might not do any good. The other thing we saw in this study was that as we increased the assist level, of course, we saw that the drive and the work of breathing disappeared. And we had two findings there. One was that the work of breathing disappeared. We had the transdiaphragmatic pressure, transdiaphragmatic pressures started to go negative, which means that you're not generating any force by that muscle. But the diaphragm activity was still at about 40% of its peak value. So that means you can unload them 100%. You can take away all work of breathing, so you become weightless in terms of breathing, but you cannot turn off the breathing because that's CO2. It has nothing to do with load. The other thing we saw was that we got a plateau. It was very hard, even though we unloaded, as you see a lot here, we could not get the volumes to change. We were stuck at 4 ml per kilo. And these are remarkable things to see, because this is really that this is the rabbit doing this. Why they're doing it, I will try to explain a bit later. Another study we did with Francois Lecomte was that we loaded the muscle instead, so we put resistive loads. So in this situation, we did like the same titration as you saw before. We increased the airway pressure, and then we got the plateau, and the Nava level continued to go up. The volumes plateaued as well. The drive went down, and the esophageal pressure swings become less and less negative till there were almost no pressure swings left. If we look upon this slide here, which is the more important one, you can see that when we did in this study was that we had a baseline. So this was before the load. That's when they were kind of comfortable. So we looked upon what was the diaphragm activity, what was the work of breathing, and the transpulmonary pressure swings. Then we put the load on with no assist, and we got, of course, an increase in diaphragm activity. A work of breathing became more, this goes negative, but it's like more than twice the work of breathing. And the transpulmonary pressures went from 2 to 4. Then we applied this titration, and we stopped at this point here, and we ventilated at that point. And look now, what level of diaphragm activity did the animal choose? Well, it chose the same level as it had when it was healthy, before we applied the load. It also shows the same work of breathing, and then when we increased the level to higher levels, we did not get an increase in the transpulmonary pressure. So again, the animal stopped at the point where the muscle was satisfied in this case. But nonetheless, when we vagotomized the animals, we saw that even if we did a vagotomy and took away the lung receptors, we could still get a plateau, but now at a different volume. So there's many factors that creates this plateau. So we can have it from probably that it's a comfort of work of breathing coming back to where you used to be, but also that we are so now we're going to go into a open chest experiment we did in Uppsala. This was Lucas Brander and Onnen Mörer was with me up there, and we did this study. And what you see here is a deflated lung. So we have like open chest, and now we're going to inflate the lung. You see the diaphragm moving up here in the back part here. Here you see the lungs come now. So what we're doing here, we're automatically linearly increasing the Nava level. And it goes on, and it goes on. But you see the lungs were inflated very fast, but now they don't change anymore. The only thing that happens is that the diaphragm activity goes down. So we can't, even if we open the chest, overinflate the lungs. So with this model, we had CT scans made. So if you look at this slide now, we have volume here, we have diaphragm activity, and we have the ventilated pressure from that experiment that you just saw. Here's the CT scan. So we go now, you see here, we move in here, the Nava level goes up on this axis here. So as we kind of move into this titration, so the Nava level is increased here, you can see that the lungs are starting to move here at the bottom of the screen. Here comes a sigh. Watch now what happens. Poof, sigh. A little bit more recruitment here, and now we've reached a plateau. So here, for some reason, the animal is already aware that this is a drive that apparently is going to work for me. So he doesn't increase the drive anymore, but you can see the volume is continuing to increase. The drive is continuing to go down, and here comes the other sigh. And watch now. Poof. Half the lungs recruited. And now he doesn't seem to increase transpulmonary pressure anymore at all. And the drive is now down towards like a plateau where he doesn't decrease the drive much anymore. But we are down now to such low values that if you decrease this level from this case, like the numbers here are very high, but still the relative decrease here is much bigger than the relative decrease was up there. So to half the drive is very simple now when you're down at low levels of activity. So we continue to do this, and what you will see is here that the last sigh that comes here is just going to open the lungs perfectly. And here we are. Totally restored lung. This is an anesthetized animal with an open chest that has done this without even knowing what he's doing. So we did this in healthy animals. We did it in animals that were with acute lung injury. We did it invasively with invasive ventilation, so intubated. and we did it with non-invasive ventilation, and then we did it after vagotomy. And see what happened with the vagotomy is that they tended to overshoot and then come down and plateau at another level. And that is a CO2 response, we believe, that they are not so fast, the CO2 receptors. So after vagotomy, CO2 receptors don't answer quick enough. And going in here, we have the Hounsfield units, the diagrams here. So this looks upon what the lungs, how they were recruited. And what's most important here is that in the healthy animal, we had normally aerated and poorly aerated lung regions were about the same. But when we went into the post-acute lung injury situation, invasive or non-invasive, only all alveolus were normally aerated. So the recruitment was enormous. The FRC was shifted upwards. And the animals did everything they could do to keep the lungs open after you had destroyed the surfactant lining of the lungs. But they did it all by themselves. Once we put the vagotomy, the lungs just fell apart and the FRC could not be held and they started to collapse. So they got a lot of atelectasis. Now finally here we have the thing we try to rule out what happens in a titration now if I reduce the dead space. So this is a study that Taibo Chu did with me 2 years ago in Toronto, and this is also in rabbits. But what you see here is the tidal volume, transpulmonary pressure, breathing frequency, and means ventilation in an animal with acute lung injury having 2 lungs. So what they choose is a tidal volume of 5 ml, and technically we could just look at the tidal volume. Now we collapse the lungs and we re-recruit 1 lung. So we have 1 open lung, but 1 collapsed. Dead space is double. Sorry, dead space is the same, half the lung. What is the tidal volume? Same volume. Now we do, on this one, we cut away the healthy lung. So we cut the vagal nerve on the healthy lung. What happens? Well, tidal volume jumps up. Then we expand the lung that was collapsed, and the volume goes down again. And this is with a single vagal nerve removed, which is not typically what you see if you have a bilateral injury. So how do we explain this? Well, it is a defense pattern, but I try to show this again in some simple illustration. So if we talk about dead space and lung size with the same VT and the same dead space, so a 6 ml per kilo breath would give you an expansion that we say is this much as the brighter area here. Take away 1 lung, so here you have 2 lungs, so tidal volume is 6 ml per kilo, you get 3 ml per kilo per lung. Now we give 6 ml to 1 lung. Well, 1 lung, we have tidal volume of 6 ml per kilo, but we get 6 ml per kilo per lung in this situation. So we expand this lung twice as much. If we have the typical situation, which might be an ARDS patient, well, you would maybe have the baby lung. That is that you have 2 half lungs. You give a 6 ml per kilo, well, you get 3 ml per kilo per lung, but since you still are like in this situation, you are still expanding both lungs twice the amount. So you have like, in this situation, same 6 ml, but in a different scenario, you might get like that the expansion of the lung might vary tremendously. And I think that's something to keep into consideration. But an animal cannot, therefore, as we saw, we could not reduce tidal volume to half when we took away 1 lung, which means that if you get more loss of lung, even Nava would kind of force you to breathe with a higher tidal volume for that lung. It would be more expansion of the lung when you breathe. And to round off, I was the one to say that we shouldn't be too long. To round off, we have shown this in humans. And I think we have now 12 studies of 164 subjects that demonstrate in different ways that there is a downregulation of DDI and a plateau in the pressure/VT tidal volume with increasing Nava levels. More importantly, papers on published tidal volumes and breathing frequency in acute respiratory failure shows adult studies, 12 studies of 181 patients shows mean tidal volume of 6.8 ml per kilo, and in the infants is 6.4 per kilo, and that's in 136 patients over 7 studies. More importantly, I I think we also have, like that Christian Karadianidis will tell us about here, that when they did this in ARDS patients during ECMO, that very few patients actually got over 6 ml per kilogram when they were on Nava, even if they had no ECMO flow. So I think that there is definitely a protection. Like lung receptors act to protect against lung deflation and overdistension, but they will be overridden for protection of the chemical milieu. And I can say, like CO2, for example, is a poison. So if you have a lot of endotracheal tube that comes out and then a little flex tube there, so you actually have a snorkel to breathe through. Anybody who breathes through a snorkel increases their tidal volume. Now, if your lung tissue is reduced because of ARDS, that's a very bad combination. But it would be that for any mode of ventilation. And now it acts as an added respiratory muscle to protect the respiration within the boundaries given to maintain sufficient alveolar ventilation. So with proper neural response, increasing Nava level downregulates the EDI, allowing the termination of patient effort reduction. You cannot really get the tidal volume you want. You cannot get the pressures you want, really. You have mostly what you can do for sure is you should be able to downregulate the drive. And the ventilated patient remains property of the patient and normally stay at low levels. Thank you very much.